on the role of IgA2 in IgA nephropathy pathogenesis. Our primary speaker today is Dr. Li. Dr. Li is a postdoctoral fellow and physician in the renal division at Beijing University First Hospital. She received both her Bachelor of Medicine and PhD in internal medicine from Beijing University. And in her doctoral training, she developed a mouse model of IgA nephropathy and began investigating the pathogenic mechanisms of the IgA subclasses. Joining Dr. Li are two discussants who have worked closely with Dr. Li, including Dr. Jiang, who is an associate chief physician of pathology and practicing renal pathologist at Beijing University First Hospital, as well as Dr. Liu. He is the chief physician and deputy director of the renal division at Beijing University First Hospital and serves on the scientific committee of the International IgA Nephropathy Research Network and is co-chair of that network in China. So welcome, Dr. Li. Thank you for being here today, and we're excited for your talk.
Thank you. Now I show my screen.
That looks great.
Oh. Thank you, host Tom, for the kind introduction. It's a great honor to join this Global Confounder Seminar. My name is Ren Li from Peking University First Hospital. Today, Lei Jiang, Jicheng Lv, and I will share our work. Our presentation is titled The Pathogenetic Role of IgA Subtypes in IgA Nephropathy, with a special focus on the role of IgA2. Our talk will cover 4 parts. First, background and scientific question. Second, IgA subtype deposition patterns and clinical significance in IgAN patients. Third, pathogenic difference of IgA subtypes in IgAN mouse models. And finally, discussion and conclusions. Let's begin with the background and scientific question. As we all know, IgA nephropathy is the most common primary glomerulonephritis worldwide, with an overall population incidence of at least 25 per million people. However, the prevalence varies greatly across countries and regions. In Asian countries like China and Japan, the annual incidence is about 50 and 45 per million people, whereas in Europe and the United States, it is lower, around 10 to 30 per million. IgA nephropathy is characterized by deposition of IgA complex in the glomerulomesangial area, with diverse pathological and clinical manifestations. According to the 2017 Oxford classification, patients may show mesangial hypercellularity, endocapillary hypercellularity, segmental glomerulosclerosis or attention, tubular atrophy, interstitial fibrosis, and crescent formation. Clinically, the disease ranges from asymptomatic hematuria and proteinuria to end-stage kidney disease. The prognosis is poor, with a 10-year kidney survival rate of only 54% in UK to 61% in China. The traditional view of the IgA pathogenesis is the multi-hit hypothesis. It starts with the elevated level of galactose-deficient IgA1, Gd-IgA1 in the circulation, which triggers the formation of specific antibodies against the hinge region. Then the immunocomplexes deposit in the mesangium, activate complement, amplifies inflammatory cascade, and ultimately cause kidney injury. The hinge region of IgA1 contains 9 potential serine or threonine sites for all glycosylation. Normally, 3 to 6 of these sites are all glycosylated. In Gd-IgA1, the addition of the gal is reduced, although cohorts from multiple countries have confirmed that the glycosyltransferase risk alleles C1-GALT1, C1-GALT1C1, which is also called cosmic, and GALNT12 are associated with elevated Gd-IgA1 levels. GWAS studies have not yet clearly identified an association between these risk alleles and the pathogenesis of IgAN.